for those of you that aren't familiar, Concordia recently established what we call a School of Health. It's really a new entity to try to give visibility to our health researchers. We don't have a medical school, and our health researchers tend to be quite scattered across multiple faculties and campuses. So it's a way to sort of bring visibility to us both internally and externally. We actually had a dean, Véronique Pepin, appointed last year, and I was just appointed this year as an associate dean. And my mandate is in research and infrastructure. So one of my goals is to try to sort of synergize some of those resources across campus, to try to bring in the expertise that's required to support research activities in health. I also want to point out that we had identified, and I think Simon was heavily involved in this, 3 research areas that the School of Health is going to try to sort of support in terms of hubs or pillars. These are the Biomedical Sciences and Engineering Research Hub, the Clinical Research and Prevention Hub, and the Community Health Hub. So the idea is we really want to use these hubs to sort of promote sort of interdisciplinary or cross-sectoral research across within the disciplines within these areas, both academically, but also in terms of experiential learning or other types of education as well, and community, right? So it's not just restricted to research activities. I already mentioned that one of my mandates is infrastructure, and the School of Health is physically at the Perform Center, which is a center that had been built with various suites that can support research activities. We have things like athletic therapy clinic, we have a clinical analysis suite, we have a cardiopulmonary suite, you get the idea. So these can cover a large range of research activities that are in the school. But I'm also trying to synergize with other research centers at Concordia to sort of, really get access to a broader range of expertise and resources for people that are in different disciplines. So I'm going to stop there to not take up too much time. If anybody is interested in subscribing, we have a health distribution list. And we also have our School of Health inaugural conference, which will be held next week. So please visit our website for information on those things. And at this point, I'm going to hand it over to Simon. I initially asked him for some titles to say, how could I refer to Simon properly? And I realized there's too many titles, Simon. So I'm just going to say, thank you very much, Simon, and I'll leave it to you.
Fabulous. Thank you very much. So Simon Bacon, I'm a professor in the Department of Health Kinesiology and Applied Physiology at Concordia. I'm also the co-director of the Montreal Behavioral Medicine Center, which is a Concordia, UQAM, and CIUS Nord-Île de Montréal research center. And I'm going to act as MC today and chair this session. And so what we're going to do is a little bit of housekeeping ahead of time. So obviously, Rebecca Wyse is going to present. I'm going to introduce Rebecca in a second. During the presentation, if you could keep your microphones closed, that'd be great. We will have a discussion period at the end. If you wish to ask a question, you can either type it into the chat, or if you want to raise your hand and ask it live, you can do so. And I just want to remind everybody and let everybody know that we're recording this session. It will be posted on the School of Health website and probably on the MBMC website as well, just to make people aware. And with that, I think I'm good. And what I'm going to do is just do a very brief introduction of Rebecca. So Rebecca's a behavioral researcher who specializes in the development and evaluation of digital behavioral interventions that are there to support prevention and treatment of chronic diseases. She's an associate professor in the School of Medicine and Public Health at the University of Newcastle in New South Wales. She's currently a research fellow with the Cancer Institute of New South Wales, and she also holds an honorary fellowship with the Heart Foundation of Australia. Her current research focuses on helping cancer patients better prepare for and recover from their surgery and their radiation therapy. And she also has conducted prevention research across a range of risk factors for cancer, cardiovascular disease, asthma, and obesity. Her interventions have been adapted for different population groups, adopted in statewide prevention plans, rolled out across the local health district, and reached thousands of New South Wales school students. And I think Rebecca is a fantastic example of how a lot of behavioral science is actually quite disease agnostic. And most of the principles that we understand about behavior and behavior change can actually be applied in many, many different areas. So with that, I'm going to hand over to you, Beck.
Thanks, Simon. Thanks, everyone. I'm really pleased to be here today. I'm sorry I'm not there in person, but thank goodness for, the technology that can bring us all together, even, from across the world, but also from just down the street. So I'm very grateful for that. Yes, look, today I'm going to talk to you about the Recovery Support Program of research that we've been running. And I just wanted to acknowledge before I get going, all the people that have been involved in this. So we have a team of clinicians and a team of researchers, and we've had that are currently involved, but we've also had a really extensive team contribute to this in years gone by and do some formative work that has kind of led to this. So I just wanted to acknowledge them before we get going. Okay, so by way of setting the scene, I'm from Newcastle, which is about 2 hours north of Sydney. So we've overlaid the map of Canada here. So you can see near your west coast, there's a little dot Sydney, and Newcastle is about 2 hours north of there. So yeah, it's a lovely spot on the east coast. We are a coastal town, so we have some beautiful beaches. Not too far away, we have the Hunter Valley, which you may have heard of, which is a famous wine growing area, famous for its Shiraz and the Semillon that it grows there. And we've also got the University of Newcastle, which is where I sit. We've got our city campus there in the top left-hand corner. And we also have sort of a campus that's a bit out of town, set in bushland, which is really lovely. So please do stop by if you're ever in the area. Okay, but today we're here to talk about the RecoverEsupport guidelines and this program of work that we've been doing. Just going to rearrange my screen a bit, sorry. Okay. Yeah, beautiful. Okay, so this program of work is based on ERAS guidelines. I'm not sure if any of you have heard of those. They are Enhanced Recovery After Surgery guidelines. And there's good evidence. These are international guidelines, I should say, and they're developed by a panel of experts. And following these guidelines, there's good evidence that can reduce patients' length of stay, reduce their complications, and speed up their recovery. Now, most of these recommendations are implemented by clinicians. So that could be use of a particular anaesthetic protocol, something like that. But some of these recommendations are actually in the direct control of the patient. So patient-led recommendations. And this is where the focus of our research lies. So there are ERAS guidelines for about 20 different types of surgery, and there are more being added all the time. So here are just some of the ERAS guidelines, and I'd be really interested to work, to know if any of you are working with these patient groups, how kind of applicable you think this approach might be. So please let me know if you think there's application there. So the guidelines span the perioperative journey. So they start when the patient's at home, they continue in hospital, and there's also activities and recommendations for after discharge when the patient gets home. So for example, I've just taken some of these. These are from the breast reconstruction guidelines, but some of them are common across all of the guidelines. So things like early mobilisation. Patients should be mobilised within the first 24 hours after surgery. Patients should be encouraged to take food and fluid orally as soon as possible, ideally within 24 hours. And this is a common one too, balancing multimodal postoperative pain management. So a balance of opioid and other types of pain medication. Patients need support to adhere to these recommendations. These aren't things that patients will just do by themselves. We know from systematic reviews that adherence varies a lot, but it can be quite low. So up to, as low as 5% for things like early mobilisation in some settings. So we need a way of supporting patients to do these things that won't burden an already, stretched hospital system and hospital staff. And so a digital health intervention seems like it might be appropriate in this case. And that's really what we're investigating. So the initial work that we're doing focuses on 2 patient groups. So that's people undergoing bowel surgery, bowel cancer surgery, and breast cancer surgery. So in terms of bowel, there's over 1.8 million cases per year worldwide, and surgery is the most common treatment for bowel cancer patients. But with that surgery comes a high risk. So there's a high readmission rates, relatively high rate of ED visits post-surgery, and high rates of complications. So that can include things like leaks and infections. And this, with it comes a high cost. So there was a study done which suggested that the average readmission rate was 8 days, and that came with a cost of about $9,000 US. With breast cancer, that's a more prevalent cancer. So that's 1.3 million new cases a year. In Australia, that translates to about 20,000 cases per year. And worldwide, this is about 12% of all new cancer cases. Again, as with the bowel, most patients will go on to have some surgery. And the expenditure on breast cancer, at least in Australia, and I believe, I'm not sure of the worldwide trend, but certainly in Australia, the expenditure is highest on breast cancer compared to any other cancer. And that's largely due to the high numbers. Okay, so the origins of this research, well, it really started with a clinician question. So the clinicians, in particular the surgeons at the John Hunter Hospital, had done some great work implementing the ERAS recommendations for the clinician-led recommendations. So they had protocols in place and they'd done a lot of work and made a lot of gains. But there was still some gains to be made because they hadn't had much success in changing the patient-led recommendations. And so they wanted to know whether we could adopt or implement a behavioural intervention and use behaviour-trained principles to improve adherence to these recommendations. And essentially what we would be doing would be empowering patients to be active participants in their own recovery. So this is an overview of the program that's kind of resulted from that sort of simple question, really. We've used the New South Wales Scalability Guide here to help decide how we would approach this. And this is basically local or state criteria that's been developed to help decision makers and policy makers decide what is a safe bet, what makes sense to roll out at a state level. And I guess it's probably it's probably similar to the MRC model, the underpinnings here of the approach to research. So in order to answer these questions, I'll just go through. So basically we've got, a general question about the effectiveness of a digital approach for these recovery behaviours in surgical patients. And so to answer that, we're looking at conducting a systematic review, and that will span all patient groups. We're looking at a needs assessment to see if this sort of thing, if there's a gap, I guess, in what patients are receiving. And then we're looking to do some acceptability and feasibility work to basically pilot and test the intervention to see if this is going to be appropriate to deliver, and if we can also deliver a fully powered RCT in the case of the breast cancer. We're conducting an effectiveness trial for the bowel cancer patients, and we'll also be looking at a question of cost effectiveness, because ultimately, if it's too expensive, it's not going to be adopted. So this program of work is funded by my New South Wales Cancer Institute fellowship, and also through an NHMRC partnership grant, which is where the funder contributes matched funds from the partner. And so in that case, this is the hospital, the John Hunter Hospital, or the health district. Okay, so I'm just going to go through these one by one. So our systematic review is in progress. So we're looking at patients having surgery in hospital with an overnight stay. And we're specifically looking at interventions that aim to increase adherence with more than one patient-led ERAS recommendation. And one of those strategies has to be delivered digitally. That's always we've always found that a little bit of a tricky thing to define what a digital intervention is. And when you have these multi-component interventions, what is it? What are you defining as a digital intervention? So we sort of said at least one strategy. We're comparing that to other interventions or usual care. And the outcomes that we're interested in are obviously adherence, but obviously clinical outcomes are really important in this instance. So things like length of stay, readmission rates, ED visits and complications, but also patient measures. So things like quality of life and quality of recovery. So this is well underway. We've searched 5 databases, no date restriction, and we got about 2,500 titles and abstracts that we've screened and narrowed that down to 60 full texts. I wish we had some results for you today, but we're still in the process of analysing that. But I did just want to let you know that that work's going on, because as far as we can tell, there hasn't been a systematic review that's looked at this problem before. So yeah, we're hoping to have those results out soon. Then moving on to the needs assessment. So this was a survey with 150 bowel cancer patients who had had surgery in the past 18 months. And this allowed us to really identify gaps in the information and support that they had received in relation to their preparation and recovery from surgery. This is just a little bit about the survey development. We developed the survey specifically for this study. And of course, they were based on ERAS, the ERAS pathway, along with some other things. We had an expert panel involved, and we pilot tested the resulting survey. And this just tells you the domains that it covered. So as per the ERAS guidelines, it spans the whole perioperative pathway. Okay, and what we found, I guess the key findings in relation to preparation and recovery from surgery were that there was shortcomings in, I guess, in the information and support that they received about the impact of their pain medication, and specifically how it affected their bowel and their recovery. And also about the pre and rehabilitative behaviours that they could perform, so their diet and exercise, how they can manage their symptoms, and psychosocial support. So we took from this that they weren't getting the information and support that they needed to allow them to play that active patient role in their recovery. And we thought there was a need for an intervention here. And that's how the recovery support intervention was developed. So I'll just give you a really basic overview of the bowel project. I'm going to go through these components in more detail later for the breast project, but the digital health, it was a multi-component intervention. So we had a website, which you can see in the top left there. And the website contained various modules with videos, and the videos were presented by the treating clinicians. So in this case, this is Sanchez, she's an anaesthetist. At the end of the video, there were some quick quiz questions, which were basically checking in to see that they'd understood the key components of the video that relate to the behaviours that they need to perform. And also, it's not up on the slide. This is the prompts and cues that we use to contact patients, to remind patients and clinicians. But a key element here is that we're reminding patients to complete a daily checklist, which goes through the key recovery behaviours and asks them every day to check off if they've been able to do it. And then that information flows through to the nurse. So here you see a prompt that's given to a nurse to say, hey, the patient hasn't been out of bed today. Can you check on her? And that's in the course of their normal ward rounds. So it wouldn't be an additional visit that they would be making as a result of this. So we've done some, once it was developed, we did some qualitative research and tested it with 11 people, 10 of whom were former bowel cancer patients, and we also had a carer. And the take home was that the program was considered very acceptable, and the majority of participants indicated that it was relevant and easy to understand and helpful and anxiety reducing. So all things that we were keen to have the program reflect. And so on the basis of this, we kept going with our research. I probably won't go through these, just to say that the qual threw up a lot of suggestions for how we could improve the project, or sorry, improve the intervention. And most of these we were able to implement. They were sort of quite simple to do. A few things remain unactioned, I guess. So we're still looking to investigate acceptability, or what we can do for people whose first language isn't English, and also what revisions would be needed for people with disabilities. So they're still ongoing pieces of work. Okay, and then the next step was to conduct an effectiveness trial. So it's a 2-arm RCT. And we're aiming to evaluate the effectiveness and cost effectiveness of this RecoverEsupport digital health intervention in bowel cancer patients. And our primary outcome for this trial is length of stay, but we are also interested in a raft of secondary outcomes, as you can see there. So days alive and out of hospital, ED visits, quality of life, health service use, the behaviours and knowledge related to the ERAS recommendations, and acceptability and use. So we're partway through that trial, and I guess I'll probably just stop here to reflect on what we've learnt so far from the process before we launch into the breast side of things. So some sort of painful lessons, I guess, we learned is that, you know, when we were engaging our contractors to develop the website, we could have really benefited from a very clear idea of what we wanted. I think we were letting that sort of develop and imagining that we would work with them to develop something. But in actual fact, there was a lot of technical difficulties there, and we actually blew half the budget just working out if the website could connect with REDCap, which was going to be the trial management system. So we've learnt from that. And I think, you know, in the breast project, we've just used REDCap. So we've actually delivered everything via REDCap. So I'll show you that in a minute. Another interesting finding was about the need of the support people modules. So this came out of the qual. Obviously, we had a support person there. But in the actual trial, what happens is the patients are recruited and then can refer their support person to the trial if they want. And what we found is that they just weren't inviting their support people to be part of the trial. So that's not to say that the support people aren't using the intervention, but I think we rejigged our systems and spent kind of a lot of time and money making the trial compatible. So we'd measure the role of the support people and how they found it. And yeah, that patients just weren't inviting them. So the content is still in there for support people, but it's about that, you know, how much do you program specific trial pathways to measure stuff. You know, and I think, you know, had we had our time over, we would have piloted. We would have learned a lot from that. And particularly where having trouble getting our sample size, which meant that we've gone to another site. So we've increased the number of sites. And that's caused some problems in terms of a trade-off between, you know, developing a bespoke system to make it as easy as possible for the clinicians involved in the trial when they're recruiting and things like that, versus then taking it to another hospital where there's different processes and different ways of doing things. So those systems needed to be rejigged. So there's, yeah, definitely a trade-off there in terms of getting buy-in from your clinicians because you're making it very simple for them and tailored to their process versus trying to, you know, take that to another site. So yes, I'm sharing those in the hope that there's something in there for you. We've certainly learned from them, and yeah, hopefully you won't make those mistakes. So moving to the breast project now. So the aim here is to increase adherence to the patient-managed ERAS recommendations for breast cancer patients that's having a mastectomy or reconstructive surgery. So the intervention that we've developed is based on the COM-B model. We identified barriers to adhering to these ERAS behaviours and then identified the functions that we wanted the intervention to perform. So you can see here we're talking about education, persuasion, training and enablement. And these are the BCTs that we have incorporated into the intervention to perform those functions. So we've got information about health consequences coming from a credible source, use of prompts and cues. We've got some self-monitoring, some feedback on the behaviour, goal setting and review of those goals, demonstrations of behaviour and instructions on how to perform them. And then we've operationalized those into things like videos, text, involving the surgeons, the anaesthetist, the nurse, and the exercise physiologist in the delivery of that information via videos. We've got demonstrations, video demonstrations of how the exercise physiologist recommends they do their exercises. So previously they were just given a sheet, but the video means that they can actually do the exercises along with the exercise physiologist in real time. We've got the daily checklist, as I mentioned with the bowel project. We have that in the breast project as well. So that's in hospital, a daily checklist to check off those behaviours, and that information gets fed to the clinicians. We've got some quizzes, emails. The prompts and cues take the form of emails or SMS reminders, and the goal setting and review is a step-by-step online process. So I'm just going to go through some of those things now. It's important to note that this intervention was developed with clinicians, so they worked alongside us each step of the way in terms of developing the content and the messaging and the delivery. So this is us filming the videos in the surgical suite. So we've got our surgeon and our anaesthetist and the 2 breast care nurses. So we sort of talked about sort of abstract recovery behaviours, but just to make this really concrete, these are the behaviours that we wanted to change in hospital. So these are our target behaviours. We've called them the 5 RecoverEs, thinking that that might be an easier way for patients to remember them. So we've got elevate yourself. So we're asking the patients to get themselves up and get moving. We want them to eat and drink as normal. And relatively quickly. We want them to do their exercises that are prescribed by the physio. We want them to ease their pain, and that's about getting the balance between not being being able to do their exercises, move around, do deep breathing without needing a lot of pain medication, particularly opioids, and also emotional self-care. So recognizing that what they're going through has been, a significant event, and that, just taking the time to reflect on that. So this is obviously a simplification of the guidelines that I showed you at the beginning, and hopefully, as we said, just a way of making it a little bit easier for patients to remember them. When they start the program, those that receive the intervention will get this prescription letter. And this is a letter from the surgeon saying, we are prescribing this program to you, and these are the steps we want you to follow. And this, we got really good feedback about this from patients. So they said, oh yeah, if my surgeon had told me to do this, then, I definitely would have done it. So we'll see if that's the case, but they certainly liked the idea that this was recommended, and there was a very concrete recommendation from their surgeon. Now, this is what the website looks like. So as I said, it's not actually a website, it's actually a REDCap database. And we did that so that we could preserve the security features of REDCap and, holding patient details without having to connect to a separate system. And it seems to have worked quite well. This is the landing page where they first come. And then this is the home page. So this is where they navigate to the different intervention modules. Now they can proceed through those in order, or they can access them in any order that they like, and they can come back and do them as many times as they wish. These are, some explicit instructions, again, from the surgeon. So we're saying the surgeons recommend that you use this program at home, in hospital, and after your surgery. So there's an expectation that this sort of spans that perioperative pathway. This is one of our clinician videos. So this is Owen, the breast cancer surgeon. And in this video, he basically introduces the target behaviours to the patients. He explains what they are, and he also describes why they're important and describes how to do them. I'm just going to show you a little clip now. Let's hope this works. Let me know if you can't see.
As a patient, we want you to be actively involved in your recovery.
So maybe you can't see.
Back on the ward, there are
we can hear but can't see.
Okay, I'll just play a little snippet.
Reduce the risk of complications, infections, anxiety, pain, and the use of opioid pain medications, and can help improve mobility and strength and help your wound heal. To help you remember them, we're going to refer to them as the 5 RecoverEs. These include, number 1, elevate yourself, get up and get moving. Number 2, eat and drink. Number 3, do your exercises. Number 4, ease your pain. And 5, emotional self-care. Let's look at these in more detail and why they're important. It's important to sit up, and get moving around the ward as much as possible.
I might just stop that there. I'll just flick back. So I guess this is a still from that video. So it's set in the surgical, in theatre. So they'll get a visual of what, you know, it will be like. We have put text on the screen and highlighted, you know, key points. And this is all feedback that we, sorry, the reason I'm bringing this up is this is all feedback from the first round of qual that we did with the bowel cancer patients. So we're able to generalize that feedback to these videos as well. Okay. Okay, and again, at the end of the video, there's a summary of the key behaviours. So advice on what to do. And this makes it easy, I guess, to flick in and out to check again without needing to rewatch the video in whole. Why it's important. It was interesting. We got some good feedback from the qual. You know, a former patient said to us, "Oh yeah, the nurses were always coming in telling me to get up, get up, get up." But I never really understood why until I read this, and I realized that it would help me. she had no way to ground why that was important. And so it's interesting, just simple bits of information can actually help make a lot of other behaviors make sense, I guess. Okay, and this is an example of the quiz questions at the end of each video. So these were designed to reinforce the key messages of the video. So confirming that they understand what the target behavior is and confirming that they understand why they're doing it. So they would also get real-time feedback. So they got positive reinforcement if they're correct. And if not, they're provided with some more information about that. And that's done in a very sort of gentle way. Now, this is the daily checklist. This is what they get each day of their admission. So they're asked to fill in this brief checklist. It only contains about 6 questions. And so, for example, this says, since coming to the ward yesterday, I did not sit out of bed. I sat out of bed for less than 4 hours. I sat out of bed for 4 hours or more. And again, there's positive reinforcement if they've done the target behavior, and if not, they're provided about brief information about how they can achieve it. And importantly, I'll just say this is the prompt that the patients receive each day to complete their checklist. They're reminded to do the behaviors and asked to complete the checklist. And then that information is automatically emailed to the McGrath nurses. There are specialty breast cancer nurses, and they would be seeing the patient every day of their admission. And so they might get a notification. I should say too, they'll only be notified if there's anything that they need to see the patient about. So if the patient's meeting all the thresholds, doing all the behaviours, that's fine. If they haven't attempted their checklist, or if the answers that they give indicate they're not meeting the behaviours, then our nurses, Beck and Helen, will go and see the patient. And then we should say too, there's lots of good reasons why, you know, that might not have happened. The patient might be too unwell, or, you know, they might have been with the doctor at the time. So the system, we've got the trial management system allows Beck and Helen to record the reasons why either the checklist wasn't done or they couldn't go and see the patient. And this is an example of the instruction videos that we provide. This is Emma. She's the PhD student on the trial, on the program, and exercise physiologist. And she's demonstrating some of the exercises that they need to do. Okay, and this is our goal setting. I'm really interested in how to kind of operationalize this. And so if any of you have any suggestions about what you've done in the past that worked well. At the moment, we don't provide any input into their goal setting. So we provide examples and we provide sort of prompts to help them check in, is your goal specific? You know, have you specified the number of times you want to do something, or but ultimately it comes down to sort of patients going, yep, it's specific, or no, it's not specific, and changing accordingly. So that it's a stepped process. But yeah, I am interested because I know a lot of us are doing goal setting in our interventions. So any thoughts on that would be appreciated. We're also able to, we also had consumers involved in the development of this intervention. So the Cancer Voices is the peak consumer body in Australia for cancer patients and survivors. And we had some of their representatives work with us on developing this intervention. We also, once it was developed, we also ran another qualitative study. So we had 10 former breast cancer patients. And we're in the process of writing this paper up now. We're still sort of analysing. But I'm going to share with you some of the quotes because it does help, I think, to bring these experiences to life and kind of make sense of this intervention program and what we're trying to do. So the characteristics of the qual participants were broadly similar to the broadly representative of cancer patients at the hospital that we're working at, which is the Calvary Mater Newcastle. And what we did was we wanted to better understand patients' experiences of preparing for and recovering for surgery. So we wanted to know, about their expectations of surgery. And we've got a range, as happens with qual, we've got a real range of experiences here. So I didn't even Google search it. It was just what I was told from a doctor. He was really good. He gave me all the information, through to the second participant who, went to oncology journals and hospital websites and books and online research. Another person sort of used a lot of publicly available information. So from Breast Screen and the McGrath Breast Care Nurses and BCNA, that's the Breast Care Network of Australia. So they have some great resources. So accessing those, those reputable sources that are promoted. And then I guess, of course, people hop online and who knows what they're going to find. So I needed to know exactly what would happen. I just typed in Google, everything, whatever, read people's experiences. A lot of my information came from scouring Facebook groups of women with breast cancer. It becomes very overwhelming and quite scary about what other people are going through as well. So I found it not at all helpful. And then the final quote there, I read a lot, but I stopped reading. Well, I got depressed because you're reading too much. So I guess women are coming into this experience with a range of knowledge, and our program is able to accommodate for that. So we also asked about acceptability. They had 2 weeks to access the program. And at the end of that, we asked them what they thought about it. And the responses were really positive. So they said, look, if I'd had that in the beginning, it would have been such a lifesaver. I found it really good and it covered everything that I would have wanted. It gives you a bit of confidence when you are lacking a lot of confidence. It puts a bit more control in your hands. I did think back to my experiences. It would have been just brilliant to know. And this person said it would have been immensely helpful. So that was all really positive. We also took from the program a lot of things that we could improve. So like the list for the bowel cancer, they had lots of good suggestions about how we could make this more helpful. And most of those we were able to incorporate in the final iteration. And encouragingly, I think they also provided feedback that the key messages that they took home was that they could be more in control of their recovery and play that role of the active patient. So quotes like, you need to be really engaged in the process and you need to participate in your own recovery. You can be in control of how your recovery progresses. And this one, I think it was the 5 E's or whatever it was. And it doesn't really matter. They can't remember exactly that. We're going to send them lots of text messages that go through the 5 recovery. But it's more that concept or that understanding of the role that they can play, which we think was coming through in the qual. Okay, so that leads us to our pilot trial. So we're looking to evaluate the recovery support in terms of its feasibility and acceptability. And determine the feasibility of running a fully powered RCT. So it'll be a randomized design, and we'll have half getting the usual care and half getting recovery support. We'll be recruiting breast cancer patients that are having either a mastectomy or reconstructive surgery at one Newcastle hospital. And of course, they need internet access. We'll be recruiting from the pre-op clinics and the private rooms. So some surgeons will see patients in private rooms and then operate on them in the public hospital. So our recruitment pathways have had to be a little bit diverse to accommodate those different types of patients. And we're looking to get a sample of about 70 patients. Here are our outcomes. So we have feasibility targets that we're hoping to hit. So we've got, as I said, 70 patients, and we're hoping that we have 80%, 85% in the study follow a 1-month follow-up. And similarly, that 85% of data, we have data for 85% of participants. And we've also got some adverse events. So in terms of falls, muscle pain or discomfort, and anxiety, we'll be monitoring those things. And in terms of acceptability, we'll be monitoring each component of the intervention that I've presented to you today. We'll be monitoring the acceptability. We'll get an overall measure of usability with the system's usability scale. And we'll also be able to collect pretty good engagement data from REDCap, you know, logons, time on website, videos viewed, that sort of thing. These are the outcomes that we're interested in for the RCT, for the fully powered RCT. So we'll be checking that we can collect all of these things. Working with a bunch of clinicians, everybody has outcomes that they are interested in. So there's a diversity of outcomes there. But importantly, we're also going to manage you know, future health service use or health service use during this period of time so that we can really get an idea of cost and you know, that'll inform the cost effectiveness. So the next steps are that the pilot starts, hopefully when I get back to Australia, hopefully we'll start recruiting next week and run for about 2 years. If it is acceptable and feasible, then we'll progress to a larger RCT. And then, you know, if effective and cost effective, hopefully expand to other New South Wales hospitals or Australian hospitals. The implications, I guess, of this program of research is that we're hoping it's going to answer a series of research questions that I identified at the beginning and provide some good evidence of the acceptability, feasibility, effectiveness, and cost effectiveness of this approach to people undergoing surgery. And I guess the vision here that we had for this program, that if it works, that it can be broadly applied to other patient groups and other people having other types of surgery. And it was lovely that one of the participants in the qual kind of echoed this vision back to us. So she said, I don't think it's something that could just be restricted to breast cancer. I think there's things in there that could be incorporated to all surgeries. So that was lovely to hear. Obviously a long journey ahead of us. But yeah, that was great to hear that fed back to us. So that's the recovery support program to date, what we've, you know, where we've taken it and the sorts of evidence that we're collecting and building. I've got contact details there, so please feel free to reach out down the track, but hopefully we can have some discussion now. And I am around like online for the next couple of days. And I'd also just like to acknowledge my the funders and the partners that have made this possible. So thank you very much.
Thank you thank you very much, Beck. Do you want to stop sharing your screen and then we can then open it up? We've got about 15 minutes or so for discussions. So I'm going to see if anybody has a question. I've got a ton of questions, but see if anybody else has something to start with. And if not, I can. All right, I'll get the ball rolling. Mm-hmm. Great presentation. And one of the things that struck me that was really interesting was being able to incorporate this into REDCap. And so, you know, that's we use REDCap, but we've sort of not quite figured out how best to leverage this. And so one of the things I was thinking about as you were talking around that was how much of the sort of usability piece and how much of the that you know, that aspect, not just the general UX stuff, you had thought about, and if you got any feedback in terms of whether that was the optimal situation for the participants and so on.
The main thing that in the first version, the screen wouldn't adjust to the size of the device. And we got a lot of feedback about that. They hated that. They said, I would not continue with that. So once we solved that problem, there wasn't really too much feedback. We did prompt in the qual, but I think they generally had more to say about the content and whether that matched up with their particular experience or not. So we did sort of probe, but didn't get too much feedback. So we've taken that as, okay, there's nothing too badly broken there. I'm sure it can be improved. And I'm sure too, REDCap it's not really designed for this. So I'm sure that you could get much more sophisticated kind of interfaces and systems. But I think so far we're going okay with our REDCap model. It will be interesting to see, when we get more detailed acceptability data at the end of the pilot trial to see, what exactly they think.
Wonderful and fabulous. Just a reminder, you can either raise your hand or if you want to throw a question into the, Nicole, go ahead. But if you could throw a question into the chat as well, if you don't want to raise your hand.
Thanks, Rebecca, for the talk. It was great and super interesting to me, as you know, because we're doing some similar stuff in pediatric cancer population. I think we kind of chatted about this a couple days ago, but just curious, it sounds like you have some content around pain management, but largely the pharmacologic pain management. Just curious about your thinking behind that, or have you thought about maybe anything around like pain education more generally in recovery? And we think of often that balance kind of, right, of like there might be some pain and that's okay, you still need to do your physio and keep kind of going, and differentiating between like pain that indicates serious kind of stop now, don't continue your physio, versus like that's normal in recovery.
Yes.
Yeah.
So I think the way that we've kind of approached pain is really to say you shouldn't expect to be pain-free, and to sort of normalize a bit of pain post-surgery. And they've tried to sort of say, you should be able to talk and breathe without it being too painful. And so they've tried to give, I guess, indicators for what sort of things you should be able to do. It is largely pharmacological. What we've said is this is how you manage your pain medication rather than any other type of approach. And I think that probably reflects the involvement of our anesthesiologists. But you're right, Nicole, there are other things that we could potentially add there. And certainly, I guess in the longer term, we'd want to move to that. So we're expecting that they use this really for the acute period in hospital, and that they may have some follow-up afterwards. They may check in about, things after discharge. But I think given it's that really acute period post-surgery, that's why we were focusing on medication. But I definitely think there's potential there to, expand the focus.
Yeah, it might be a nice fit, because we know the farm side is like, where you're going to get the most bang for your buck in terms of pain management after surgery. But even framing it as kind of like there's distraction, there's deep breathing, like it seems to fit well in kind of the multimodal sort of approach that you mentioned. But cool.
Yeah, I agree that it could be, definitely broader.
Wonderful. Next question. Okay, I'm going to ask the next question. So what, just in terms of the program, is it relatively linear in terms of people getting stuff in, it's like you start with A, you go to B, then you go to C, and then etc. Is there much? So the question of customization and sort of the capacity to maneuver between modules, et cetera, the balance there and your thoughts around that.
So it's quite linear in terms of our communication with them. So we have a series of email or SMS communications that are sort of pre-programmed based on their date of surgery. So they get information, reminders to check the program. They get a packing checklist, which means that they can take things like shoes and clothing that allows them to walk around the hospital. So, that's all very prescriptive. But they are free to move around the website however they want. That's not prescriptive at all. That's sort of, they have free reign there. So there's a combination, I guess, of a very linear pathway, and then once they get to the website, they can do what they like. Yes.
Yeah. Okay. So that then leads me to my next question, because one of the things that we've been thinking a lot about with our digital tools is, how do we best leverage, some of the machine learning elements about creating windows where we're always a great fan of choice, but sort of more structured choice, right? So that you actually sort of put things towards people that may need it, but may also resonate with it. And so you sort of create a somewhat personalized path that enhances the experience that they have and makes it easier for them to maneuver through that.
Yes, so there's definitely potential for that here. And in fact, we are just collecting a little bit of data. We're actually going to randomize, collect some pilot data, like a nested pilot within it. So we're asking people about their preferences for how often they're reminded to do their exercises at follow-up. So we'll have a set 3 times a week schedule, but then people will have the option to set their own schedule, and we'll be looking at to see if that affects the engagement, how often they do their exercises, and log their experience. So yeah, we are interested in those sorts of questions, and this doesn't, I guess we're trying to get a little bit more information about how we could use those in the future. There certainly is potential to do that, but this is fairly I guess this is our base level model. And it would be great if in future we could, have tailored pathways and bespoke pathways based on preference and, what we know people are going to respond best to. So I think there's definitely potential there, Simon.
Yeah, cool. And I'm guessing within REDCap, you probably can get statistics about what people accessed and when they accessed it and the order that they accessed, which also is really nice data that could feed into the development of future models as well.
Yes, that's right. You can timestamp what they access. So you could get quite a rich picture. I mean, I think it's subject to the same limitations as websites. You're not sure how active they are, or, if they leave their browser open, the clock keeps ticking. So it's subject to those limitations, but yeah, you can get quite good data.
And then I have one more, which I'm going to circle back to your question, which is the goal setting question.
Oh, yes.
Oh, wait a second. John has a question. So John, you go ahead.
Well, actually, I'll just set you up, because I was actually going to, on the goal setting, just based on sort of the way the ontology has kind of evolved, there's like 5 different children goal setting, I guess, quasi BCT, or different kind of flavors or different ways to break it apart. So I was just going to you'd mentioned it earlier in the presentation, and my thought was just, it might be worth going into the BCIO. I don't know if you were in that workshop.
Yeah, I was. Yeah.
You were. So if you went in and you put in goal setting BCT, you're going to see there's like 5 different kind of children, I guess they're going to call it in the ontology, that might give you some ideas for just how you could play around with the presentation of goal setting within, I don't know much about for cancer population, so I'm not going to venture a guess.
No, but that's a good point, John. Yeah, I hadn't thought of doing that, but you're right. That's more detailed, and that may help translate it into sort of an online tool, I guess.
Well, it just might just prod your creative juices and some of your intuitions, right? To how else can I pull this apart in the context of an intervention?
Yeah.
No, thank you. That's a good point.
Cool. And then I'll just add my 2 cents quickly. How we're conceptualizing this, because obviously goal setting is a cornerstone of most behavior change interventions. And in our digital space, what we're thinking about doing is developing effectively a core module, which is really about how the basics of goal setting and sort of explaining what is a goal, explaining SMART goals, and sort of something that's very generic, and then thinking about how do we then tag context-specific information onto that. So we're thinking of building blocks, right? So you'd get the core module, anybody that was doing anything would get the core module, and then oof, here is the one that is for diet. Here's the one for whatever behavior, right? And that would have sort of more specific examples of how people may conceptualize the goal setting in that context, right? So giving them a frame. And then we sort of try and get them to set up their goal. And part of really the proof in the pudding, as it were, is then having them monitor the goal and come back and say, did you achieve it or not? And then if not, take a step back and say, okay, well, is there some more work we need to do around making, some facet of the goal better, like work on a certain aspect? If they did achieve it, then it's like, great, you're doing a fabulous job. Do you want to set a new goal, or is this goal okay? So I don't think it's an easy thing to crack, but we're trying to think of novel ways in which we can sort of move the needle a little bit more in terms of making it useful and interactive.
Yeah, I like that idea, Simon, of a core module, because I think you're right. Like these things, there is a generalizable element to goal setting, and then if we can, specify something, more detail that's relevant to the particular context we're working on, that sounds like a sensible way to approach it.
Yeah, we're doing the same with self-monitoring as well. Nicole.
Yeah, I was just curious, Rebecca, for the more generally the ARS protocols, either in breast cancer or other groups. I know it's not set up, sorry, I'm still stuck on pain, but it's not set up to treat chronic pain, but like, do you know, is there any evidence? Because if it helped, not treat chronic pain, sorry, prevent like post-surgical chronic pain. Because if it helped do that, that would be, even in a tiny bit, which it may, given the things you're targeting. Again, it's not like everything exactly would target in that kind of intervention, but I was just curious if there's anything about that.
So I know each set of guidelines comes with a literature review, and pain is talked about in some of those reviews. I'm just not sure at what point they measure pain, if it's immediately post-surgery or 7 days post-surgery or longer term. So yeah, I should go back and have a look. It definitely is included, like they do look at pain, but yeah, the time frame I just can't be sure of, Nicole.
Yeah, no worries, just curious.
Wonderful. Well, we're at time, and I just need to do one small plug before we finish up, and then we'll, if you don't mind, and do the wrap up. I'm just going to remind everybody. So let's do the plug for the School of Health. I'm going to do a quick plug for the Canadian Behavioural Intervention Trials Network, CBITN. So this is a pan-Canadian group that's really aligned very well with this talk in terms of trying to improve the development of behaviour change interventions, and then how we go about testing them. And this is for a plug for all the students out there. There is an opportunity to get funding from CBITN for next year. If you go to the website, if you just look up cbitn.ca, you'll be able to then find the training awards. And the deadline is at the end of this month. So now is a window where you critically can put things together and get it in. So just wanted to flag that. That was my shameless plug. And with that, I want to thank Rebecca for an amazing talk. It was absolutely wonderful, and an amazing body of work, right? I mean, spanning that spectrum of getting the things up and running and then actually implanting them into practice is never straightforward. And I guess you just put a link in there.
Oh, sorry, I just put a link in because I'm not getting to meet any of you face to face. I'm just going to hang around on a Zoom link for the next half hour. If anyone has any questions or ideas, feel free to jump on. Feel free not to as well.